Welcome to Risks and Dangers of Oxygen, Session 2 of the Oxygen Masterclass. This is a live recording of a webinar presented by Julia Bott, South East Coast SHA Clinical Co-Lead and Consultant Physiotherapist for Surrey Community Health.
Right, so we're going to move on from Joe's comprehensive background of the respiratory failure and what oxygen does for us in the positive to looking at how it can be a little bit of a problem occasionally. So why has oxygen therapy become such an issue? It's reared its head in the last few years for a variety of reasons. A few years ago, the British Thoracic Society published guidelines for the use of emergency oxygen in adult patients, and you can see the link to that on your screens now, and of course, because you're getting the slides, you will have that for those of you that aren't aware of it. At the moment, there are no clinical guidelines currently for home oxygen use, but these are in preparation via the British Thoracic Society. However, last year, the Department of Health spearheaded a good practice guide to home oxygen service assessment and review, and for short we'll call it from now on the GPG, Good Practice Guide, and HOSAR, Home Oxygen Service Assessment and Review. And again, for those of you not yet aware of it, it is published on the Primary Care Commissioning website, and you can see the address in the bottom left-hand side of the slide. So the challenge for clinicians now in the South East Coast, or I should say more correctly, the South of England SHA East region, is really to understand and implement these Department of Health guidelines to get consistency in the highest possible standards. They are really helpful for commissioners to give them a sense of what services should look like, and a useful broad brush for clinicians. They're not detailed clinical guidelines, but more how the service should look. And to help get a deeper and wider understanding of oxygen, and not only how it can help, which we've heard about, but how it can actually harm patients. So there are four main dangers or hazards that we can say that exist with oxygen. There's physical injury, there's burns and explosions, hyperoxia, and oxygen toxicity, and we'll take them each in turn. Now, physical injury is fairly simple. If you use a cylinder, it's a heavy object. It's a bit of a missile, or missile, depending on your point of view. So they're very heavy objects, and we need to explain to patients actually the risk of dropping them. People can drop them on their feet or bang them against other body parts and cause problems. It may sound very simple, but where the oxygen cylinder can become a lethal weapon is when we're transporting them in vehicles. And whether you are a patient using it or whether you're a member of staff transporting it from one site to another, cylinders must always be strapped in the back seat. Don't leave them rolling around in the boot, and never leave them loose in a car that's in motion. If someone does an emergency stop with a loose cylinder in the back, it could come up and smack someone in the back of the head, and that really could kill someone. So they are objects to be treated with respect. We need to advise against dropping cylinders from a height. If you drop an oxygen cylinder from a high enough height, it will actually explode, so that's not a great thing to do. And very simple precautions like not using petroleum-based products when you're handling oxygen, and we have to be aware that some hand creams do contain petroleum jelly. So we need to make sure that our patients understand that and don't handle the cylinders when they're using hand creams or other products with any base of petroleum. I think it's fair to say that one mustn't use oxygen anywhere near a naked flame. I haven't actually put it on the list because it's what's known as a no-brainer. However, as you will see later, not necessarily for everybody. We do have to remember that LOX is supercooled, and therefore there is a freeze burn risk. So that's to be aware of. Patients at home on oxygen, particularly those who smoke, the fire service should be alerted to the fact that the patient has oxygen in the home. And recommendation 67 from NICE is that patients should be warned about the risks of fire and explosion if they continue to smoke when prescribed oxygen. And that leads us on to the knotty issue of smokers. And this causes a bit of, let's say, heated debate, if you'll pardon the pun. So in the annals of burns and fire disasters, for example, in 2006, there was a nice summary of papers describing horrendous things that happened to smokers who were playing with fire when they were around their home oxygen. So in the papers studied, 14 to 51% of LTOT smokers users were found to smoke. I mean, that can be a very high number, clearly. There were 86 cases, all told, in this paper of home oxygen burns, and 8% of these full-thickness burns actually requiring skin grafting. Now, major surgery, clearly, for patients needing LTOT is not a great idea because of their lung condition. The length of stay on average was 4.6 days, and 9 of these patients died. So not a lot of good came of it. So there was a paper in Thorax in 2006 published really to get everyone thinking. So rethinking LTOT in determined smokers. And I think if you're interested in this topic, then I think you need to be aware of this paper and have a look. It is causing quite a bit of vexation nationally, and the National Oxygen Board has been discussing whether or not the Department of Health should pronounce on one side of the fence or another as to whether LTOT should be given to smokers or not. You'll find that around the country some PCTs will fund oxygen for smokers, and in fact there are areas where PCTs won't. So now we're going to move on to the greater area of problems which taxes us on a more daily basis, and that's hyperoxemia and oxygen toxicity. And I'm going to take them together. So we have absorption atelectasis and inflammation, myocardial or cerebral damage and vasoconstriction, and increased VQ mismatch. And I'm going to take the first of these, absorption atelectasis. So I want you to take a moment to think about the gas composition of air in the room around you. I want you to think about, and if you want, you can wang us in your answers. On a postcard would be a little slow, but you could type them in if you like. What is the percentage in the room, the air around you, of oxygen, carbon dioxide, and nitrogen? So get typing quickly. Well, let's have a look at the percentage of oxygen. And as we know, most people say 21%, but in fact, it is just under that. Okay, 20.93%. So I think most people are pretty clear on that one. Carbon dioxide is only a trace. So 0.03, and because this is being recorded, I actually was not allowed to say what I would normally say, which is 2 words, one beginning with B and the second word meaning all. However, a trace is probably the most professional description. And what about nitrogen? So how much nitrogen have we got in there? Well, you're pretty close, 79%. So it's the bulk of the air that we breathe is actually nitrogen. So the key thing is, what is the role of that nitrogen? It has a very important role, and I think it's very, very clear that we need to understand why 79%, in other words, most of the air that we breathe is nitrogen and not oxygen that we breathe in and not carbon dioxide. So I can see some correct answers coming in. Nitrogen, indeed, keeps the alveoli open. It's an inert gas, therefore it can't be absorbed. That is unless you're a diver. We won't go into diving physiology, but under the increased pressure at several atmospheres below the surface of the water, divers do, in fact, start to absorb nitrogen into the bloodstream. And it's the nitrogen re-emerging as the diver ascends, and if they ascend too quickly, the bubbles of nitrogen, which are trapped in the blood vessels and haven't come back out, actually burst, and this is what's known as the bends. So nitrogen can't be absorbed at atmospheric pressure, and therefore it keeps the alveoli open. So what happens if we replace this nitrogen with oxygen? Well, that's quite an important point because it is the majority of the gas that we're breathing in. And it's really very simple. The more nitrogen that we replace with oxygen, the more oxygen will be absorbed. And that's because of the big difference of the gradient of pressure in the alveoli and the arteries. So the bigger the gradient, so the more oxygen we put into the alveoli, the bigger the gradient with the deoxygenated blood in the lungs, and so more and more of the oxygen will be absorbed. So if we're absorbing a large amount of air, what's going to keep the alveoli open? You got it, nut and honey. And that's what we call absorption atelectasis. So if you replace that 80% near enough nitrogen with a huge percentage of oxygen, a lot of it will be absorbed and the lungs will start to gradually become atelectatic. Now, if you're a bit of a physiology book freak like I am, if you look at the John West physiology books, he's got a wonderful diagram of the speed of absorption at different percentages of oxygen. And it actually starts anything above 50% oxygen. And if someone is on 100% oxygen for 24 hours, they will get absorption atelectasis. And that's why the ICU is one of the places where it's very reasonable to have someone on 100% oxygen, because nearly always these days ventilators will have positive end expiratory pressure, which will take the place of the nitrogen and splint the alveoli open whilst giving the patient very large amounts of oxygen. So it's a very important point. If someone is in hypoxemic failure, as Joe was talking about just now, or type 1 as some of us call it, much to Joe's disapproval, I hasten to add, then if we are using 50% oxygen regularly for someone in a hospital setting, for example, we need to be thinking about CPAP and splinting the alveoli open another way. So we need to be cautious about how much we give people on a long-term basis. What about inflammation, that other main problem? Well, you get endothelial and capillary inflammation with a lot of oxygen, and this causes increased capillary permeability, and it can take only 2 days at 100% oxygen for the capillaries to start leaking, and that's a bit of a problem. So you're going to get interstitial and alveolar edema, and eventually you're going to get organization and lung fibrosis. And in babies, the very delicate tissues in the back of the eye, the retina, become damaged and can cause blindness and visual problems. So inflammation plays a very important point. And sometimes patients who've been in ICU on very large quantities of oxygen for prolonged periods do end up with organization and lung fibrosis. Now, we tend to think of oxygen as, perhaps most of us are now inculcated to think that lots of it isn't good for the lungs, but we still have the received wisdom that lots and lots of it, the more the merrier, for myocardial or cerebral damage. But in fact, that is not the case. Too much oxygen can give you myocardial or cerebral problems. Too much oxygen, hyperoxia, actually leads to vasoconstriction in organs other than the lungs. So if you get brain or heart vasoconstriction, it doesn't do either organ a power of good. And there is very good evidence, and you'll find this in the BTS emergency oxygen guidelines, papers showing that this leads to poorer outcome post-myocardial infarction or post-stroke. So the received wisdom now is oxygen only if the patient is hypoxemic and only to the level that they need it. So like any other condition, we are not looking to over-oxygenate the patient. And interestingly, in normals, more than 24 hours of 100% oxygen will actually lead to parasternal pain. And 2 days of greater than 50% oxygen can produce toxic effects. So we mustn't underestimate the problems that it can cause. And I'm going to now talk about the last one, but the most important of us all in the lung field, so in respiratory medicine, and that's the increase in mismatch between ventilation and perfusion. Now, Joe has given us a good background on that, but just to remind ourselves, and I have to confess that I stole this slide from Joe, we fought over it, and because I'm bigger and stronger, I won. But this is Joe Congleton's slide, and you can see that the lungs are surrounded by blood vessels, and of course every bit of ventilated lung has to have a capillary next to it in order for the gas exchange to take place. And so when we talk about mismatch, it either means a bit of lung without the blood vessels or a blood vessel with a bit of lung that hasn't got any air in it. So where there's low oxygen, in the lung, so due to poor ventilation, for example, in parts of the lung, you get a reflex called hypoxic vasoconstriction. So in the lung, then low oxygen will actually cause vasoconstriction. And that's a protective mechanism to decrease VQ mismatch. The blood vessels narrow to reduce the blood supply, that's the perfusion, to avoid physiological shunting and problems like that. But adding the oxygen releases this vasoconstriction. So if we pour in lots of oxygen, then the vasoconstriction will actually relax and allow blood into the unventilated area of lung. So you're improving perfusion. The blood vessels widen to increase the blood supply and improve the perfusion. However, this increased blood flow, the perfusion, brings more carbon dioxide to the area, which is poorly ventilated. Therefore, it will increase the mismatch of perfusion to ventilation. And it decreases further the ability of the lungs to expel carbon dioxide. So it's a very negative situation to be in. And it's one of the reasons patients can run into trouble very, very quickly. It's the mechanism by which patients with neuromuscular disease, when given too much oxygen acutely, will run into danger very, very rapidly. So of particular danger, of course, are those in or at high risk of type 2 failure, such as those, of course, with COPD or with neuromuscular diseases. The alveoli are not able to expel CO2 effectively because of poor ventilation, which has not been corrected. So the CO2 rises, hypercapnia worsens, and as we heard from Joe's talk, pH will then fall even further, and you will get a very rapid deterioration in your patient's condition. Interestingly, however, in a randomized controlled trial of titrated controlled oxygen versus high-flow oxygen in acute asthma, it was demonstrated that there were increases in CO2 in the high-flow group. So even in patients, technically, who had the type 1 failure, it was starting to cause problems. So ultimately, we need to be very cautious about large quantities of oxygen in everyone. Now, one of the papers that has really hit the headlines is this randomized controlled trial by Austin and colleagues from Tasmania, which was for emergency call-outs for COPD. The crews of the ambulances were actually randomized, so not the patients, and crews were randomized to either deliver the usual oxygen therapy that they normally delivered, which is obviously high flow, or controlled oxygen therapy. And I want you to take a moment to what you suppose the outcome was. So which group fared better? If you want to type in your answer, feel free. So control group or experimental group, those getting their usual oxygen or those getting controlled oxygen. So Mel Etherton has come in with a correct answer. The controlled oxygen group fared better. In fact, there was a 9% difference in mortality. So the usual oxygen group had a higher percentage mortality. And if we think about it, that's an extremely sobering statistic, because this is in the ride to hospital. This is really in a very short space of time. Albeit Tasmania is quite a large country and perhaps there were some big distances, nevertheless, that's a large increase in mortality that we really don't want to be giving our patients. So the key points to consider about oxygen therapy are: oxygen is life-saving, but too much is unnecessary, as we can't store oxygen. And too much may be harmful in some patients. It risks hypercapnia, and it can be toxic at high levels, including those with non-respiratory problems. So the guidance now is only give oxygen where and when there is hypoxemia, and give only as much as is needed. No need for any extra at all. In fact, it's harmful. So now we work on target saturation, certainly in the acute setting, and there's no reason to take that, not to take that out to the home. We have no clinical guidance on this, but we can be pragmatic. So most patients without underlying problems, so if you or me get admitted with pneumonia or pneumothorax, we want to be saturated to 94 or 98%. However, those at risk of hypercapnia, so those with COPD or neuromuscular disease or other patients, we're looking at 88 to 92% and no more than that. So I just want to pause there and remind you that if you have questions, please start typing them in, because believe it or not, I'm nearly finished. I know that's a miracle, but that's how it is. So patients who need a lower and a more controlled saturation will be those with chronic lung diseases, so COPD, and other chronic lung diseases, those with chest wall disease, severe scoliosis, kyphoscoliosis, patients with neuromuscular disease, and those with obesity, hypoventilation. So we're working towards not over-oxygenating anyone. Right, so type in your questions. Right, we've got a question from Nicola. Can you recap on the effects of giving oxygen in those with VQ mismatch? So patients with any sort of VQ mismatch will probably be hypoxemic, and in the early stages they will have the hypoxemic or type 1 respiratory failure. So these patients, it's very important that we give them controlled oxygen therapy, because too much oxygen might increase the VQ mismatch, because giving a lot of oxygen into areas of poor ventilation will open up perfusion to areas that are poorly ventilated, and if that's the case, you will actually increase the VQ mismatch. Right, so we have another question from Renee about pulse oximetry accuracy. And pulse oximetry is normally accurate to plus or minus 2%. So basically, oximetry should be used only as a guide. So if you want to know exactly, then you really need to take a blood gas. But for most situations, the oximetry is fine, because you're looking for change, and in which case change is it's going to be the same. If your oximeter is showing -2, it's the same one that will be -2 all the way through. If it's +2, if it's showing 2% higher than it should, it's going to be a change of +2 all the way along the line. But we have to remember it is a sort of a ballpark accuracy. Joe's just reminded us that one of the issues we have here in Surrey, Sussex and Kent is where there are local CCAM crews can actually give controlled oxygen. And the answer has been some crews know that they need to do it. It is now in the national guidance for ambulance crew to give controlled oxygen in patients at risk of type 2 failure. And we are working very closely with CCAM to get agreement on having controlled oxygen therapy available in all vehicles.
We hope you enjoyed Session 2 of the Oxygen Masterclass. Sessions 1, 3 and 4 are also available, covering respiratory failure, long-term oxygen therapy assessment and ambulatory oxygen assessment.